very much, Richard, and thank you very much, Eric, for the invitation. I think this is an extremely exciting time we are living in, and a lot of questions, controversies, which I have no doubt will go into clinical practice because we will find the answers. And when we would do our homework, we would know many of the answers raised to the question this morning. When you look at the Tumor Genome Atlas of colon cancer, published about 8 months ago, you can see all the major players in the KRAS signaling pathway and the PI3 kinase signaling pathways. And you can see the KRAS mutation with 40%, the NRAS mutation with 10%, the BRAF mutation with 3%. You see the PTEN loss, the PI3 kinase, and when you go up, you see significant upregulation of HER2 and HER3. All the answers we need to know to predict EGFR receptor sensitivity, because when we sum up NRAS, KRAS, we go up now to 50 to 60%, exactly what we now know with the peak and prime data. But these data show even more. The upregulation of HER2, you can see here, is 6%, HER3, 4%. So 10% have significant upregulation. And we now know, and I show you data, that the HER2 amplification is one of the significant escape mechanisms of EGFR receptor inhibition. And I think this is important and maybe not become clear this morning in the different discussions, that timing and tumor progression will come along with significant changes in the tumor makeup and activated pathways, which will determine the efficacy of subsequent treatments. They stick big questions about PTEN. We all saw the publication from Lupakis in JCO, but it addresses another important issue, which is tumor heterogeneity, not only from one patient to the other, but also from the primary tumor to the metastatic site. And these molecular changes may be not the same, but also will impact the effect of our treatment outcome. I think there is still the verdict out on PI3 kinase mutation, the difference between exon 9 and exon 20 mutations. I think with the larger clinical trials with FIRE3 and 8045, we will be able to answer these. I think the major take-home message is that we are missing almost 20% in patients with colon cancer who have mutations in exon 3 and 4, as well as mutation in exon 2, 3, and 4 for NRAS. These are the patients who do not benefit from cetuximab, and when we treat them, it seems that when the backbone is FOLFOX, we may harm them. And I think this comes again as a discussion from Dr. Arnold. Does the backbone matter? Maybe, particular based on the backbone of the makeup of the tumor, not so much the interaction with the antibodies. When you add these additional RAS mutations, we have now seen in peak and prime the response rate, PFS, and overall survival increase. And with the proof that these additional mutations act like the mutation in exon 2. I agree completely with Axel. This is practice changing, and the European authorities already recognize that to make these changes, and we need to act on this because we certainly do not want to harm our patient population. And again, we had the answers many years ago. This elegant paper by Sabine Teschper's group showed, in addition to KRAS, when we know BRAF, when we know NRAS, when we know the exon 20 mutations, the response rate of single-agent cetuximab almost doubles from 24 to 41%. Better patient selection based on the activation pathway of the EGFR receptor signaling will increase the benefit for these patients being treated. So what do we do with the patients who don't have a mutation in KRAS, NRAS? Well, there are also significant work done many years ago by Kimbata Ford, who showed that the 4 gene signatures predicts the efficacy of EGFR receptor inhibitors in wild-type KRAS. Some of the major players is actually the ligands, EREG and AREG, which actually signals the significant activation of these pathways, a positive predictive marker. But I think it may be worthwhile to look at RAS activation, what really plays a role in the RAS activation, because that seems to be such an important gene, becoming more important in the future. I think we need to understand that KRAS mutations, specifically depending on the codon, may have different downstream signaling. One more goes to the MAP kinase pathway, and the other one to the AKT PI3 kinase pathway. It matters downstream what this could mean. We now get data that KRAS mutation in codon 13 are prognostic, that we know any KRAS mutation may be associated with brain metastases. The better characterization and the inactivation or activation of this pathway will clinically matter, predictively and maybe prognostically. And we have not even started to understand how the wild-type KRAS activation really is modulated. You can see big boxes with sprouty and spread, and you can see on the right-hand side KSR. All these modify the wild-type activity of RAS. Now, these actually can be heavily modulated, methylated, mutated. So in KRAS wild-type, we have additional modifiers in this particular pathway which critically modify the status of activity. But this slide also already shows there is a feedback mechanism, and you can see it comes from the ERG pathway going all the way up to the EGFR receptor. Because all these pathways know ongoing activation need to be self-limited, so there is usually a feedback included. How do we take advantage of that? Does that impact our activity or interaction with this pathway? And it's getting even more complicated, because if you have a mutant KRAS allele, that preferentially signals to the ERG pathway, and the ERG pathway biofeeds back to the EGFR receptor, activating wild-type KRAS. So you can see it's not as clean, but I think unique opportunities to potentially further modify, alternate, and influence the signaling in this pathway. I think one of the most exciting genes in this pathway is called RAS-F1A, because this can be methylated in over 20 up to 30% of patients, dramatically influencing KRAS activity. And again here, it looks like with a feedback mechanism, mutant KRAS through the wild-type KRAS allele can inhibit the activity of mutant. So the take-home message is the wild-type KRAS signaling is extremely complicated, but opens up opportunity to interfere and maybe modify the activity, as well as maybe we should take care or advantage of the feedback mechanism. KRAS cells are also acting differently within a tumor. You can see here the evolution of development of colon cancer till the advanced stage. And at the end of the picture, you can clearly see that hypoxia and oxidative stress can lead to the loss of mutant KRAS. Very new information just recently published by Dr. Parsons at the NCI. So there are actually ways to get rid of mutant KRAS, and there are examples in the literature that a mutant KRAS went into a wild-type KRAS. Dr. Teschma gave me this slide because I think it's a wonderful overview about what can predict EGFR receptor inhibitors in addition to the RAS mutations. We talked a little bit about PI3 kinase and PTEN, and I think here again, the specific mutation analysis as well as tumor heterogeneity will dictate the success of these two markers. But there are indications that the degradation of the EGF receptor pathway may become important, that actually immune response, particularly when you think about an IgG1 antibody, may become important. And on the bottom of the slide, the location will give us some clues about the activation of this pathway. I think the most consistent pictures is with the EGF receptor ligands. Here, the data from Josep Tapanero, who clearly shows that EREG and EREG are significant predictors positively of response to EGF receptor inhibitors. TGF-alpha is inversely, so we still need to have validation of this data, but this looks to be very promising to select patients who have an activated pathway. This data from Kambada-Ford show the same. In the patients treated with cetuximab with high EREG, the PFS is significantly increased, and you seem to have no benefit when the EGF receptor pathway is not activated. These are all wild-type KRAS patients. And here data from Sabine Teschper's group show again wild-type KRAS, that you have high and low levels of ligands show a significant separation of the PFS. So ligands seem to be one of the most promising positive predictive markers to identify patients who benefit most likely of EGF receptor inhibitors. This was presented at ASCO, and you can see on the left-sided colon cancer, there seemed to be significant benefit from cetuximab. On the right, it is less. How is that possible, that the location will determine potential benefit of monoclonal antibodies? Our own group looked at significant correlation between the ligands, EREG and EREG, with the mutational makeup, the location, as well as the site of metastases. And you can clearly see that the ligands seem to be associated with KRAS and BRAF mutation, with the location of the disease, as well as the presence of liver mets. In liver mets, high; in peritoneal mets, low expression of ligands. Will this give us, for the first time, some clues that actually the ligands may guide us even further than the RAS testing? And this was presented at ASCO too, because there was a whole session in the poster discussion part about the localization of the tumors. And you can see that the right-sided versus left-sided colon cancer differ. On the right, you have a high mutation frequency, and on the left, you have losses of 20q and 18q and EGF receptor activation by different mechanisms, including EREG expression. So biology goes with the location, and it's not a surprise because right-sided colon cancer are differently, completely developmental than the left. One is mid, and the other one is end gut, biologically from a different origin. Now, I don't want to give you the impression this is all about the EGF receptor pathway. We have actually presented last year, Dr. Loupakis, in collaboration with Christiane Langer from Genentech, showing significant different outcomes based on location of disease in the 2107 study. These are not published data showing clearly that the right-sided colon cancers do not as well as the left-sided colon cancer. So the differences between right and left may not only include EGF receptor, but also significant underlying prognostic and potential predictive outcomes in different pathways. I think one of the things which may have not become clear this morning is the dynamic of tumors under treatment. It matters what you get first in changing what the tumors develop into. When you treat with EGF receptor inhibitors, you can see the development of HER2 amplification. And I'm not sure if you can clearly see, but on the right-hand side, these are all quadruple negative. You see little stars. These are patients developing HER2 amplification. These are patients, and I think Axel was not kidding. It may that trastuzumab will become not only very similar to cetuximab use, but came another part of our treatment armamentarium in the subset of patients who escape EGFR receptor blockage. Another example clearly demonstrated, and both data set came from Dr. Bardelli, is showing that under this treatment with cetuximab, you develop significant upregulation of other pathways, including c-MET. These changes in a dynamic tumor obviously will impact about the sensitivity of the selection of further targeted or cytotoxic treatments and should give us some insight what our next steps of treatment could be. I think what has been not well understood, and I think this is a new area which looks very promising, is actually the degradation pathway. And that's not only applicable for EGFR receptor, we have the data right now, but this may be true for many, because it's a complicated pathway. When the antibody binds, it's internalized and degraded and recycled. If this receptor is not recycled, there will be no sensitivity or resistance to the antibody because there is no binding anymore. So it would effectively work when you can inhibit the degradation. There are two pathways, the ubiquitination and the methylation. I don't want to go into detail, but you can see all the relevant genes which are part of it. And Dr. Stinsing in my lab actually showed at ASCO this year, when you have this germline SNP in the UPC12, this significantly correlates with progression-free survival and overall survival. I think a completely new way to understand the recycling of these receptors as a potential mechanism of sensitivity or resistance. Another area which we are getting really excited about immune response, particularly with the development of antibodies against PD-1 and PD-L1. So we actually looked extensively into these different pathways and then the interaction between NK cells, T regular cells, T cells, and tumor cells. And you can see there is ongoing communication with different pathways. Now, PD-L1 and PD-1 is actually also related to the NK cell activation, which plays a significant role in the ADCC. So we looked at different SNPs and found PD-L1 germline polymorphism predicted response to FOLFIRI-BEV. This should be looked in different settings, including cetuximab. But other genes like CD24 and IOD1 are also related to significant outcome in progression-free survival. A hint that the immune system may play an additional role in the efficacy of our targeted agents. I want you to leave this meeting to understand that the revolution is now coming to our clinics. We will not only do a mutation analysis on the paraffin-embedded tissue we have done at the time of diagnosis. The tumors are dynamic, and we have for the first time the capacity to monitor mutational pathway activations in real time. This is the liquid biopsy, to isolate either free DNA in the plasma or circulating tumor cells will change the way not only we treat, but also how we develop drugs in the future. And the EGFR receptor pathway has led the way to show that when we look in the plasma DNA, we see emergence of KRAS mutation, EGFR receptor mutations, activation of different pathways, months before clinical progression. I think we need to learn much more what that clinically means, but we have for the first time a window of opportunity to show what's going on a molecular level with our tumors under our treatments. And data presented at ASCO showed that EGFR receptor inhibitor-treated patients escape with the addition of new mutations. But it seems to be reserved to the codon 61 and 146. Now, what does that mean? I think we will learn much more, but these are unique opportunities to understand the dynamic changes in these tumors under treatment. This was an oral presentation at ASCO in the non-colorectal cancer discussion. And why is it important? This is pancreas cancer pharmacogenomic models. But these investigators actually showed for the first time that when they profiled circulating tumor cells, it mirrored the molecular changes in the tumor. The correlation was incredible, giving us hope and excitement that this is a real window looking at CTCs, seeing what are the changes in the primary tumor. But the future will not stop here. Do we need plasma and blood where you need 20 or 30 cc's, which is not easy to take every time with a visit? Can we look in the urine? Because the free DNA is secreted in the urine, and I think you would agree with me, it's so much easier to collect 50 cc's urine than 50 cc's blood. These studies are ongoing. Can urine identification of tumor DNA make it even easier to collect these tumor changes in the urine rather than the blood? I think one of the major challenges we face, not only in the identification of biomarkers, but also understanding what's going on with the sequence of the response and differences of response in different sites, is really the heterogeneity we see. From one patient to the other, from the primary to the metastatic site, within the tumor itself, but also functional. We know that one of the major hurdles of our chemoresistance are cancer stem cells. We cannot kill them. They will grow out of first and second line and enrich. And that's one of the reasons we are failing in later lines of treatment. So how can we advance our understanding? And I think this Nature review is wonderful, showing that when we see a diagnosis and we see metastatic disease and we see progression of disease, we really need to try to get biopsies. And we try to get plasma DNA, and maybe in the future urine DNA, to follow the molecular changes which happen under our treatment, because only with that we will be able to treat a subset of patients much more successfully and segment our patient population to patients who treat with different target agents. So my food for thoughts. I think we have not even touched it. Does it matter if you have allele frequency of 10%, 30%, or 0.1%? I think in the future, when we talk about mutation, I think we may talk about different things. If all cells are mutated, or only 1 out of 1 million using the newest technologies, may differ. We need to address that. I think not every RAS mutation is the same. Prediction, prognosis may differ, and we will much learn more about it. There are ways to get rid of mutant KRAS with hypoxia and oxidative stress. Maybe a new way to look at this. And if KRAS is so prevalent now, going to 60%, let's develop better inhibitors of these pathways. So what do we have to do? We certainly need better validation and standardization of promising biomarkers in clinical trials. We need to power our trials to do that. We need to do more work on the molecular evaluation of tumor heterogeneity. Identifying the subclones at the time of diagnosis would give us a full picture of what's going to happen in the future and maybe start intervention treatments earlier. We need to really do our homework on the molecular characterization before, under, and after treatment, because that will point into different treatment options. And we just do more and design effective biomarker clinical trials. So I would like to thank you so much for your attention, living in this incredible time. Would like to thank Sabine and Josef for slides, and my lab and my collaborators around the world. Thank you very much.